Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation. And over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before you get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. Chief Medical Information Officers and Chief Health Informatics Officers are critical leaders in hospitals for driving informatics and innovation. They have an expertise in technology, data, and informatics, and are often practicing clinicians who deeply understand clinical workflows and the nuances of the provider-patient relationship. In today's episode, we talk to three trailblazing CMIOs who have played key roles in driving innovation for the past few decades. First, we talked to Dr. Rod Tarago. He's a pediatric critical care physician turned clinical informatics leader who spent over 15 years serving as CMIO at top children's hospitals like Seattle Children's and Minnesota Children's before joining Amazon, AWS, to lead clinical informatics and AI for academic medicine. His work is focused on improving medication safety, clinician workflows, and patient care through cloud and AI technologies. Joining Rod is Dr. Troy McGuire, the Chief Health Information Officer at Children's Hospital Los Angeles. Previously, Troy has been CMIO at Children's Hospital Orange County and Seattle Children's, where he's championed medication safety, population health, and he's optimized the EHR to improve outcomes for children and families. Dr. Tarago, you've led several initiatives to build and integrate technology to make patient care safer for children and families. What have been some of the most impactful changes you've seen in how technology improves patient safety?
It's interesting, like many things that we work on these days, I think it starts with data and getting that data to be converted into information and getting the data to talk to each other. Oftentimes, as we're working in the area of patient safety, it's really humans doing the work of getting the data to talk to each other and to be integrated and to give the whole picture. And so, what we're starting to do now is really use advanced technology and analytics to try to get all of these disparate data sets to combine and to be turned into useful information for whoever is using it at any level and allows them to use that information to make more strategic decisions. And now, obviously, we're about 2 years into the generative AI revolution, and now gone from speaking about generative AI to talking about agentic AI. But it's so exciting because we can now start using some of those tools to do things that we couldn't really imagine doing even just a couple of years ago.
So you both have currently and previously had roles that are described as CMIO or CHIO, Chief Medical Information Officer, Chief Health Information Officer. How do you see that function in an organization playing a role in this advancement of technology as it relates to quality and safety? Maybe Troy?
Yeah, I would say that the role itself grew out of the need for hospitals and health systems to have somebody who spoke three languages. They had to be able to speak enough IT to be able to follow the ball. They had to be clinically aware of what the challenges were and have credibility with clinicians when they spoke enough to be able to affect change and behaviors. And then they really needed to be able to speak administration to understand what are the priorities of the organization, what are the regulatory things that are coming at us to be able to respond. And having that trilingual competence was what we all did early on in this journey. Most of us grew up in the field by having been able to speak the three languages and then developed a passion around it to say, I'm going to give up some of my clinical time to do this because it's a worthwhile effort. And then eventually got to a point where we said maybe we're giving up a lot of our clinical time to be able to do this effectively and have enough time to focus on the issues.
And I remember Troy, when we were working together, saying there are days where he felt like we could make more impact using electrons rather than our stethoscope. And that's really what this comes down to, is being able to make an impact on multiple patients, multiple populations, multiple clinicians with decisions and technologies that we put into place in all of the different areas. And I've actually brought the same sort of trilingual approach, having left healthcare organizations and having come over to AWS. It's really exactly the same role. It just happens to be in a different venue.
And I think when I said that, it was something along the lines of, this year I may take care of 60 to 80 pneumonias as a pediatric hospitalist, but I'm going to affect another 1,200 that I'm not taking care of directly by virtue of having created order sets and standardized the approach and made it easier for the clinicians, nurses, and providers and pharmacists to do the right thing, choose the right drug, and choose the right studies.
Let's talk a little bit about data sharing and its impact on quality. I've noticed that both of you have done lots of work in this space.
The simple truth is that care is provided overwhelmingly in the home, not in a doctor's office, not in a hospital, not in an ER or urgent care setting. The overwhelming majority of care is provided in the home. And there's not a lot of recording of that care that happens. But care that happens in the school system as an extension of the home is plentiful for children who have chronic conditions. And the care that's provided in ambulatory setting dwarfs the amount, not the intensity of care that's provided in an emergency department or inpatient setting. But all of those venues are siloed from each other. And so you asked about Lanes. Lanes is the Los Angeles Network for Enhanced Services. It is what we would call a RIO, a Regional Health Information Organization. It exchanges information between those different venues of care. It's complex, but in order to do that, it has to know that you're talking about the right John Smith. So patient matching is probably the single biggest task to get right. And once you know that you're talking about the right patient, then you break down the silos of care. I don't have to duplicate tests. I don't have to send a request for a fax of something when I can already see it because it's available to me. That's what lanes and RIOs and HIEs more broadly, what California Data Exchange for us and what TEFCA federally is intending to do is create these trusted frameworks for the exchange of clinically important information so that you know who showed up where for what care and what happened during them.
If we think 5 years out, maybe even a little bit further out, what does that 3.0 look like? What does that future look, particularly with the lens around AI and generative AI?
I'm going to say Rod is the more visionary of the two of us.
I remember somebody asking me at a conference a couple of months ago, what does it look like 5 years down the road? And I said, 2 years ago, we weren't talking about ChatGPT yet. So I have no idea what 5 years holds, but I am excited by it, both on the accessibility part of things. The way we live in the rest of our lives, I think, is going to reach healthcare much more quickly. It's the ability to use ambient, to use voice interaction for things. And what we're really excited about AWS isn't going out and saying, we've got 200 and some different solutions, you should be using them all. What's really fun is going and sitting down. For example, I remember talking to a PICU nurse and asking her, just imagine what better looks like for you. And she said, why do I have to go into a room and wash my hands, then put on my gloves, then go to the bedside, then record certain things and write them down on a piece of paper. And then I have to take my gloves off, and then I have to go wash my hands, and then I have to walk to the computer and log in and so on. Why can't I just sit at the bedside and use voice to chart? Simple as that. That is using all kinds of different AI. And that is something that we could probably do today, but it's kind of a leap.
Why do they chart all of those things at all? Or could there be voice and camera vision and ambient that picks up on what's happening, or perhaps a data
Right.
integration that picks up on what's happening so that there's even less documentation to begin with?
You read my mind.
I think we've done a lot of this to ourselves.
Yeah.
We've created standards for documentation. Some has been imposed regulatorily, but I'd say we have uniformly exceeded the demands that were placed on us from a regulatory standpoint in what we decided we needed to capture. And there's a lot of other drivers for that.
Yeah.
But Rod's point is, between ambient voice, between cameras in a room, between the idea that I am a most effective clinician when I'm using my brain for the most part and focusing on the tasks that need to be completed. But I'm most effective when I have a really skilled resident following me in the hospital who is following everything that was said and then doing it afterwards. And then I just have to review rather than do. That's a good day for me. And I think that what we're looking for is that for everyone. But Rod, you used ambient voice, but I suspect that you were talking about all ambient monitors that could replace what we shouldn't be having to do in terms of interfaces.
Absolutely. And that things like we still use little pieces of sticky paper to put around kids' wrists to make sure that they are the right person in the hospital. Why can't we use palm prints or eye prints or things like that? Even right now, when we think about the ubiquitous implementation of ambient listening, mostly in outpatient settings, I've got these memories, visions of if we could do that, say, in the inpatient setting, all of a sudden, this relatively antiquated approach of a bunch of people coming into the hospital very early in the morning and looking at the computer and writing a bunch of stuff down on a piece of paper and then regurgitating it to the attending. And then the attending goes off for 3 or 4 hours and documents what was just told to them. That kind of goes away if you're able to record the entire conversation at the bedside. And even more exciting for me, because I've had a couple of experiences with this, I would love to, in the events of something not going right or an error being made or an adverse event occurring, wouldn't it be great to go back and listen to the rounds interaction for those 3 days preceding that event so that we can learn from it? Nobody's really talking about the educational and the learning opportunities with ambient. Right now, it's mostly around decreasing work effort, improving efficiency, but those are the things that to me are really exciting.
All right, let's talk about patients and families. How do we use technology to just make life a little bit better for patients and families that we're serving?
There's quite a few. So let's start. Why don't we just use a patient portal as the prime example? Patient portals that are tethered to only your one EHR is an old model, but it's one we're still trying to implement. And there's some challenges in the pediatric because of adolescent space in particular around that. But we've largely got past the point of the paternalism and moved into autonomy, and we've embraced drivers that included 21st century cures and info blocking as motivators to say, no, the record really is the patient. And when they can see what we know about them and they can use that in their interaction in their daily life and feedback to us, then we have better outcomes because they're a more informed, more engaged consumer of our services. So that is something I wholly believe in. But what good is that if they can't get into it, if they can't create an account in the first place, or if their care is being provided at 4 different places, each that has their own portal that aren't speaking with each other, or if what really would have made a difference is the content of the note, and the note itself is either in such dense medicalese that they didn't understand what the recommendations were or their condition, or, and this is assuming they got into it and could read it, it's not in the language that they actually use. So having patient portals with low burden of participation that, like our RIOs, break down the silos between the venues of care, treat it as a patient-centric record of everything I need to know about myself, but then take it one step further and say, what does it mean? Like, how do you use AI to extract the real signal, the real meaning out of all those labs and those radiology tests and upcoming appointments and their notes themselves in a language that is culturally and linguistically appropriate for them? That's what I see as the big win of the informed, engaged patient.
Yeah, absolutely. And oftentimes those are termed as boring applications of generative AI, but they're huge. In the United States, 25% of the patients don't have English as a primary language. And 99% of patients don't have medical speak as their primary language. And so the ability to take some of these tools and not just translate the headers of a document or the pre-created content of the document, but in real time, use it to translate either from English to another language or from medical to non-medical, do it in a way that still keeps humans in the loop. My mom is a Spanish medical interpreter, and she just can't reach all of the patients who need it. And even if she can interpret for all of the patients, they're still going home with documents in English. And so that is something that we could do today across the board if it is something that is deemed important enough.
And we're doing some pilots of that with Spanish, and it's certainly our biggest need. But we've confined it to only ambulatory because inpatient is more complex. And there are a lot of barriers of taking it to the next step, but those barriers seem like they are easily surmountable by multinational companies that have linguistic competence. And we are way past the era of we don't trust
Yeah.
machine translations. They are better than going home with nothing, and that's more often what we're giving patients. There was a study I just read today that looked at 500 hospitals across 17 states, and only 5% of them offered their portal in anything other than English and Spanish. And less than a third of them even offered it in both of those languages. The opportunities are huge.
And this is a great example of many times in healthcare, because we're protective of our patients by nature, because we're relatively conservative, we are risk averse. But when we start using the current state rather than perfection as our baseline, all of a sudden it's a tremendous opportunity. We may say, yes, the large language model or the computer translations are 98% accurate. Now, some might look and say that's a 2% error rate. On the other hand, we might say, yes, but what is the error rate on a document that is entirely English? It's 100%. And so having the conversations around where are we now and where could we go, even if it isn't perfect, is where we should be doing.
Troy and Rod, thank you so much for spending the time. It's always fun chatting with you both. Thank you.
Thanks
This
for
is
the
a blast. Thank
opportunity.
you.
It's good to see both of you.
And now for your dose of dad jokes.
All right, what you got today?
Why did the scarecrow always win an award? Because he was outstanding in his field.
Okay. It's pretty good. Pretty good. What else you got?
Well, I'm reading this great book about anti-gravity. It's impossible to put down.
Okay. Okay, I like it.
This next one's more like a riddle. What's orange and sounds like a parrot? A carrot.
Next, we talked to Dr. Shaun Miller, Cedars-Sinai's inaugural Chief Health Informatics Officer, a role he assumed in January 2025. In this capacity, he oversees all clinical informatics, and he supports physicians, nurses, and allied providers across the health system. Previously, he spent years as their Chief Medical Information Officer, where he led the rollout of virtual care models and telehealth solutions, advanced EHR optimization, and piloted AI-powered technologies like AI scribes and augmented response systems. So CS Connect is really interesting. It's been a couple years since it's been live, and I think it's been a year and a half since Pediatrics has been private, right?
Yeah.
So what is it? And particularly for parents and children, how does it play into the options that they may have as it relates to caring for their kids?
So CS Connect, it's really our platform to expand kind of Cedars-Sinai's ability to provide access to care. And we know it's often hard to see our clinicians in the office or during working hours. And we, had this vision for a while to try to offer more of a digital first option. We've obviously seen telehealth grow and the potential to provide care to families in a variety of different ways. And the platform, largely primary care, and it's actually set up through a joint venture between Cedars-Sinai and a company called K-Health. And we built the platform together, leveraging K-Health's expertise in delivering virtual care, leveraged by AI, actually. There's a lot of AI and triaging that happens and vetting before a patient actually decides to enter a visit.
I've used it, right? You're interfacing with it seems like a chat bot for a while, doing intake, symptom assessment. It seems like there's some triaging there as well, right?
You enter into it. You can either be a new patient to Cedars-Sinai or an existing patient. It immediately knows if you're an existing patient, it can hook into your prior records. And it immediately starts to have a conversation with you in terms of why are you here for your visit and gets you down a certain path. Some of it is via the acute path. You're feeling sick, cough, cold, your typical, maybe more virtual urgent care type of conditions. And it'll start getting a little bit more information around what you're actually experiencing and give you a little more context, give you a guidance around what it potentially could be. So the AI actually plays into helping you determine what the series of symptoms, and through that kind of interaction can either give you a sense of reassurance right off the bat. You don't even have to see a clinician through that platform. But after going through the questionnaire, it gives you the option of jumping into a video visit either right then and there. So there's the on-demand approach, but there's also the scheduled approach. And that's where sometimes you may not need to see someone right away, but you're at work, you're not feeling great, but you want to see someone at the end of the day, or you want to see someone on the weekend, either for that acute type care or chronic care, primary care. If you could establish a relationship with the CS Connect physician, primarily to manage things like blood pressure. We have an RPM program, remote patient monitoring program, specifically for blood pressure on CS Connect now. But what we're also doing is those who have an existing Cedars-Sinai primary care physicians, the CS Connect platform is being embedded into primary care as an extension of your kind of brick and mortar physician. So that's another nice element. So if it's a really busy month, but you really need to get that follow up on your blood pressure or get adjustment, get some labs, check your cholesterol, you can just make that quick appointment on the weekend, talk to a CS Connect doctor who has access to your whole record, has access to the plan of care from before, and can keep things going if you can't get to a doctor soon enough. It's really a combination of access to the care that you need and that kind of convenience factor for a lot of the kind of more straightforward conditions.
I'm curious, your hypertension care model that you were describing, where you've got a doctor managing your hypertension or your cholesterol, and you can engage virtually with a CS Connect doctor in between. If you're not able to go in person, you can do it virtually. I'm curious if that it could extend to pediatrics someday. Kid with diabetes, kid with asthma, something that's more pediatric oriented, where they're being managed by a specialist or a pediatrician, but the virtual could play a role from a remote patient management standpoint.
Absolutely. I think we're seeing some appetite even at Cedars-Sinai for a lot of post-discharge monitoring patients that maybe are discharged from the NICU. We've already seen it over the years with bilirubin and jaundice monitoring. And I think there's absolutely just so much appetite to get your kid home and get your kid care. And so I think a lot of it's just really the clinical protocols that you can put in place. I absolutely see opportunities in the kid world for sure.
You're introducing this concept of a care team that is not just your one doctor, right? So if you're being managed by a specialist for your hypertension or by an internist for hypertension, now you're talking to a different doctor perhaps on the weekend because that's who's available through the virtual option. And you're instilling trust in the patient. The doctor I'm talking to on the weekend, because of the digital systems that are interconnecting my record and my chart and the CS Connect platform, that the doctor I'm talking to knows everything about the history that I have with my in-person doctor, but also that what I talk to this virtual doctor about, that information will get conveyed back to my regular doctor who I have trust with, right? You're creating this extender model, which has to be based on this trust between the patient and the virtual team that you're introducing them to.
Myself, clinically, I'm a hospitalist, and I think that whole movement and the growth of that field was the evolution of recognizing, one, healthcare has always been a team sport. You may have your quarterback and you may have kind of your primary care physician, but especially through interoperability and access to your records through the EHR and just good communication models, you can build that trust that your primary care doctor is part of the care team with the hospitalist to take care of you in the hospital. But now, yeah, the concept of virtualists, other clinician extenders, but that care team, including pharmacists and nurses and social workers, all sorts of clinicians can manage your condition if they're all functioning well as a team.
So at some point, I think people are going to say, if it's going to take me 6 weeks to see somebody and it's going to cost me a ton of money, there's a trade-off perhaps that you could get good enough information through AI that may be more cost effective.
I mean, technology should be making things cheaper. And you're right. I don't think healthcare has realized the same kind of gains there, partly because of the economics, to your point around payers and a lot of kind of fixed overhead and for health systems.
Well, Shaun, thank you again. It's always fun talking to you. All right. Thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and thank your crossing guard. And if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast. CHLA does not endorse the views, opinions, and information presented on this podcast, and CHLA specifically disclaims any legal liability or responsibility for the podcast content.